Hello there. I hear you have had some unusual symptoms, it looks like. Yeah. Would you mind telling me a little bit about that? Okay, I'm just going to be typing along as you tell me. Okay. Okay. And when did these symptoms start for you? Okay. And is this associated with any type of injury at all that you know of? The affected area. Okay, good. And on a scale from 1 to 10, 1 being not bothersome at all and 10 being the worst pain you've ever experienced, how is your pain level right now with these symptoms? Okay, and is that normal or is it usually better or worse? Okay. All right. So there are a few things that I want to check for first off. So it is interesting that you say this isn't associated with an injury, but I do want to check for arthritis, of course, and we might be dealing with maybe some tendinitis. So I'm going to start by looking at your joints, okay? So if you could just give me your arm here. All right, let's start with the elbow. So you said this is multiple joints that you're experiencing these issues with. Okay, so what I'm looking for is redness. We are looking for warmth in the joint. I'm looking for reduced range of motion as well. Does this feel tender as I'm pressing along the joint? Okay, it is. Yeah, it's quite tender. Okay, now I'm just going to move your elbow around here. So you just let me take the weight of it. I'll move it how I need to. So we're just going to go up and down. Up, down. Okay, and how about internal rotation? External rotation. Internal. External. Okay. Okay, and let me look at your hand here and your wrist. So the joints themselves are not warm to the touch so far. Okay, no redness, they all look normal in color. So I'm going to just move your wrist around. We'll go these different movements right here. Just some passive movements, and then I'm going to squeeze your metacarpals here. Let me know if that's painful. Is that painful? No. Okay. Let me just check each of the joints of your fingers. Okay. Let's look at the other side. So, elbow first. Have you had this happen before? Not so much. Okay. Let's see. Right, so not red. And is this tender here? It is. Okay. Well, so far I'm leaning more towards tendinitis. Let's look at the wrist, and then we'll get our ranges of movement. Squeeze the hand. No pain. Okay. Each of the phalangeal joints. Okay, so let's go ahead and move the arm up and down, just like that. Up and down. Okay, and the wrist will move up, down, in and out. Rotation, and the elbow internally rotates, externally rotates. Okay. Normal range of movement. Okay, that's interesting. So, question for you. Is there anything that makes the symptoms better? Have you tried heat, ice, resting, any over-the-counter medications? Okay. Reports. No, really. Symptoms. Okay, so not heat or ice. That's interesting. You've brought me a tricky one, because tendinitis often responds to that, and you don't happen to use any bracing at all, do you? No. Okay, well, I might have an idea, but we're going to look at a few somewhat unrelated places for it, okay? So let me look at your skin first off. I'm going to check the skin on your hands and your arms. And I'm going to try to pinch that and look at the elasticity. Okay, so it's got a good amount of give to it, and you look like you have quite a few little scars here. Do you happen to bump into things a lot? Do you get a lot of bruising? Yeah, you're pretty much always got something going on. And how would you say your rate of healing is? Okay, yeah, I couldn't tell either way. Yeah, that makes sense. Does it feel like things take a long time to scar over, like weeks maybe? Okay, I'm gonna look at your face here. We're just going to look at the texture. So on your hands and arms and your face here, you have really nice skin texture. It's very soft. Do you happen to use a lot of moisturizer? Okay. Right. So I see a few spots here and there. We're just gonna look at the neck. Okay, do you mind if I look at your legs? Again, I'm looking primarily for scars for wounds, and signs of bruising, lots of cuts. Okay, your legs are pretty banged up, and that's normal. Yeah. Okay, so and fragile skin. Okay, so I am going to take a little look at your eyes, all right? And I want you to just stare right at my nose. Okay, it's kind of hard to tell. Just keep looking at my nose here. All right, let me grab my light. We'll let it warm up for a second. Tap the end, make sure that's not. Okay, so go ahead and keep looking at my nose here. Okay. Alright. I think that's what we're looking for. Okay, so what I'm seeing here is something called a blue sclera or blue sclerae, which basically means that the whitish grayish sclera of the eye on you has a blue tint to it. And that is indicative of a few different things, and the particular thing that I'm looking at. Blue sclerae. So, something that I want to check. I don't know if you get regular vision assessments, but something else I want to look at is any visual degradation. So I'm going to just real quick bring out the Snellen chart and we'll see how your eyesight is. Okay, so we have our Snellen chart here. And I'm just going to have you read the letter or the line that I point to so we can assess how your vision is doing. We're going to start very simply right here. What is this letter? Okay. How about line 2 right here? What is this letter? Good. And what about right here? Okay. Line 3, 20 over 140. What do we have right here? Good. Yep, good. Okay, and how about line 4? But we're going to do this one backwards. Okay, right here. What's this letter? Good. And here. Okay. Right here. Yep. And right here. Good. Line 5 right here. 20 over 70. What's this letter? And this one. Good. Yep. Good. Okay. We're just going to keep going down the line here. So line number 6. Yep. Good. Yes. Excellent. Now, below this line right here, line 7, 20 out of 40, we're going to do this one backwards. So, if I could just have you tell me what this letter is. Good. Yep. Good. Good. Okay. And line number 8, 20 out of 30. Right here, what's this letter? Good. Yep. Yes. Good. Good. Okay, now 20 out of 25. Can you tell me this letter? Yep. Good. Good. Yep. Yep. Good, okay. Line number 10, 20 out of 20 vision. If we could do this one backwards. Good. Yep. Good. Good. Very good. Perfect. Okay. Would you mind just covering this eye for me here? Okay, and we're going to start again just below this line between 6 and 7. If we could do this one backwards. Good. Good. Yep. Good. Good. Yes, okay. And then let's just jump below this line. Good. Good. Yep. Good. Good. Okay, good. All right, let's do this one backwards. Line number 10. Good. Yep. Good. Excellent. Now, if you could just cover your other eye for me. All right, and we are going to do line number 8 right here. Okay. Good. Yep. Good. Good. Yep. Excellent. Okay. And if we could go to line 10 and then do that forwards. Yep. Good. D, C, E. Oh, excellent. That's perfect. So we're going to want to keep an eye on your vision, and I do want to look at your jaw as well as your spine, all right? So first with the jaw, I'm going to feel around here. Do you happen to get a lot of clicking or popping with the jaw? Okay. So I'm going to have you do a few things here. So I'm going to have you first clench the jaw. Go ahead and clench. Unclench. Clench. And unclench. Okay, and was that painful? Okay. Now I'm going to have you open and close the jaw you're going to open it as wide as you can, okay? Go ahead and open the jaw. Close. Open. Close. Open. Close. Okay, and tell me about that. Was that particularly painful? It was. Okay, so does your jaw feel a bit off now? Yeah, okay. And dysfunction. Right, so we're going to want to take a look at your spine. I just want to make sure there is no scoliosis or an abnormal shift one way or the other. We don't want any abnormal kyphosis or lordosis, which is the curvature of your spine. We don't want it to be too far in or too far out. So if I could just have you turn around real quick. Okay? And then we're going to take a peek here. All right. Do you tend to have any back problems? What about your neck? Okay. All right, that's good to know. So, luckily it looks like upon initial inspection, there are no signs of scoliosis. So I'm going to have you bend forward, and you are going to very slowly, vertebra by vertebra, come back up, okay? I'll see if there's any abnormalities in the spine that way. So go ahead and bend forward. Very slowly come back up. I'm just going to watch here. Okay, good. That all looks normal. All right, you can come back around. Good. Now, I am going to recheck your joints here, but I'm going to do it with a specific goal in mind. And I need you to tell me if your joints feel more sore as I'm doing this. Okay? So let's start with your elbow here. I am going to bring this up and then down. We're going to see how far down this goes. Okay, so how does this feel? Alright, so this is hyperextended. Normally, your elbow should stop right about here, but you've got a little bit of hyperextension in there. And let's take a look at your thumbs. So can you bend your thumb quite a bit far backwards? Okay. So we do have hyperextension in the thumb as well. Let's look at the fingers. Oh, those are pretty. Well, the pinky does hyperextend a bit. Okay. Let me check the other side. So we'll bring the elbow in and then out all the way. Okay. So hyperextension in both elbow joints there, and the thumbs. Definitely hyperextensive there. And these fingers, definitely the first finger and the pinky. So we have some in the fingers. Okay. Let's take a look at your knees. So I'm going to have you kick out your knees as far as you can. Okay, yep, it's not supposed to do that. Right, and the other one? Yep, that joint's not supposed to bend backwards like that. Okay. Go ahead and relax the knees. Let's take a look at your feet. Okay, we've got some stretchy toes here. Definitely pretty flexible here. Okay, interesting. Alright, patient demonstrate. Okay. Alright. So I am going to ask you quite a few questions about your personal and your family history. If you yourself have dealt with this particular symptom or condition or situation, or if you know of someone in your family has, it can be immediate family, it can be extended family, okay? So I'll ask you questions and I will type up the responses, okay? Okay, let me just go ahead and get to our page here. So, very first thing, have you or has anyone in your family been considered double jointed? Okay, and have any other members of your family experienced joint pain? Alrighty, and anyone with a history of migraine? Very good. And how about allergies? Any allergic reactions at all? Any hives, rashes, any anaphylaxis? Okay, yeah, contact dermatitis would be one of those, yes. Okay, and how about any food intolerances? I mean, this could even be just lactose intolerance or could be anything else. Okay, yes, lactose intolerance is common. Okay. Okay. And how about chronic fatigue or ME/CFS? Okay, maybe. Okay. Let's just for now put no, and I'll put a note in there. There we go. All right, and how about dysautonomia or POTS syndrome? Okay, not really sure what that is. Well, I do have a few situational questions that might be able to answer that a little bit better. Okay. How about Sjogren's syndrome? That is an autoimmune condition. No to the Sjogren's. Okay. And anyone have ADHD? Yes. Okay. And what about autism or autism spectrum disorder? This might have been diagnosed at one point as Asperger's before 2013. Okay. And how about anxiety? Does anyone have generalized anxiety disorder? Okay. And how about gastroesophageal reflux disease or a lot of issues with acid reflux? Okay, very good. And how about IBS or irritable bowel syndrome? Okay. And Raynaud's phenomenon. Yeah, that one's a bit of a deep cut. You might see where someone's fingers in particular are the easiest to see. They're very white and they look very patchy, might be very cold. Okay, yeah, you would know it if you saw it. So no on the Raynaud's phenomenon. Okay. And how about PCOS? Polycystic ovarian syndrome. Anyone with that? Okay. And how about endometriosis? Okay, good to know. And PMDD, also known as premenstrual dysphoric disorder. This is a very severe form of PMS. Okay, so maybe, all right. Okay, and how about MCAS, or mast cell activation syndrome? Okay, and bipolar disorder. Okay, now a few more situational things. Do you or anyone that you know in the family struggle a lot with heat intolerance, or when it gets very hot, you get really tired, really irritable, just can't stand to be in the heat? Okay, and when you or someone you know stands up, you might get that head rushing feeling where you feel dizzy, you feel like you might black out, you might get spots in your vision, your body feels really strange. Okay, yeah. Okay, so last couple, do you experience a lot of odd sort of joint popping, or maybe when you get up, you might just have your joints making all these cracking sounds? Have you ever maybe popped your sternum before? Collarbones you might feel popping with? Okay. Alrighty, and last one, and this one's going to be a bit odd. Do you or anyone in your family experience odd reactions to medications? What I mean by this is maybe if you take allergy medicine but it doesn't do anything, or you take acetaminophen, ibuprofen, and you really don't have any effect unless you have a higher dose. Or, for example, you might not process opioid medication. So if someone gave you morphine or Tylenol 3 or something, you can't feel any sort of effect. You don't get any pain relief. Okay, so I think that we have a pretty good idea of what's going on here. So it looks like what you are dealing with, and this can be diagnosed just by the family history. It can be diagnosed with the elastic or stretchy and fragile skin, as well as the issues with your joints. This would be something called Ehlers-Danlos syndrome. And what this is not just one disease, but a collective disorder that deals with your connective tissue. And the reason I ask all these other questions is it has a ton of comorbidities that we see pop up along with it. So Ehlers-Danlos affects the connective tissue, which is all throughout the body. It's in your skin, your muscle, your organs, your blood vessels. It is part of your entire body. And part of the structure of your body is not quite right, essentially. Now, there are 13 types of Ehlers-Danlos. The most common one is hypermobile Ehlers-Danlos, and we can do genetic testing as well, and we are going to want to do that because there are certain types that come with a lot of complications that we need to keep an eye on. But even at its most common, I believe the current number is it's 1 in 5,000 people. So if you have a city of 100,000 people, you will very most likely find about 20 people in that entire city that have Ehlers-Danlos at its most common. Now, it probably is more common and just isn't diagnosed yet, but we do not have those numbers just yet. As we research it further and as more people get diagnosed, we'll have a better idea of how prevalent it actually is in the population. So we're going to want to have a little bit of a chat about this. So first off, Ehlers-Danlos, or EDS, is highly genetic. It is very likely that if you have siblings that they have it as well, that one or both your parents might have it as well, and extended family may also have it. So that's something to keep in mind if someone is complaining about any joint pain. They might want to get checked out for Ehlers-Danlos. And as we mentioned before, it does have a lot of comorbidities. We also have to deal with a higher risk of injury and of dislocation, as well as the joint pain. Let me go ahead and just get out my little sheet here. Our little guidelines. Okay. Okay, so I'm going to switch to this. So we are going to try to do some genetic testing if that's okay with you. Almost every single type of Ehlers-Danlos can be tested by genetic testing. There's only one of them that can't, but that actually works for us, because if you don't test positive for any of the other types, that means that you have hypermobile Ehlers-Danlos. Now, as far as managing the condition, this is a condition that one is born with. This is not something that can be cured, and treating the disease itself is not really what we're doing. We are managing the disease. So as far as pain goes, what we can do is we can use topicals on specific joints. I think there is an ibuprofen topical, or you might have seen like the Bengay, or you might have seen like the lidocaine kind of thing. We can give that a shot on specific joints like your elbows, your knees. We can also try to do acetaminophen, ibuprofen, or naproxen. That's going to be pretty much our range for pain medicine. And naturally with Ehlers-Danlos, many people don't metabolize these medications like other people do. So you might have to have a higher dose to feel any relief. Some medications may not work at all. That's part of the fun part, but it would be very helpful to keep a record of that as well, so that we know what works and what doesn't. So another thing we can do that's very helpful is bracing the joints. So if you have any arm braces, if you use one of those carpal tunnel braces for your wrists, braces for your knees, that does help quite a bit and helps stabilize the joint. You could also use kinesiology tape as well, the KT tape, and tape up the joint. That will help quite a bit. And we also want to think about mindful moving. And that sounds a little silly, but we want to make sure we're not locking up any joints, that we're not overusing joints, that we are not overextending them. And we want to make sure that when we're stretching, we're being very careful about it. Again, not overextending things, not overworking the joint. Now, I asked you earlier about dysautonomia and POTS syndrome, and then I asked you about if when you stand up, you get those head rushes and whatnot. So that is a symptom of dysautonomia. And we see a lot of people with EDS that have dysautonomia, which basically means that your autonomic nervous system, which helps control things like your blood pressure, your heart rate, your temperature regulation, it doesn't work correctly. It's a little goofy. So we can address that, actually. So for dysautonomia, the very basic things we can do without involving any medication, we can increase your water and your sodium intake. I can give you a little pamphlet on what the range we want to hit is for that. And if it's really bad, we can also have you wear compression leggings. So I believe right now our guideline is 25 to 35 millimeters of mercury as far as the pressure grade. And that will keep you from having your blood rush to your legs and not being able to come back up. So instead of pooling in your legs, the pressure helps to force it back up. So if you're very unsteady on your feet, very weak, very lightheaded when you're standing for a while, then we can do that, and that should help quite a bit. The other thing is avoiding different triggers. So a big trigger for people with dysautonomia is heat. So not taking very hot showers, not being outside when it's very hot, that sort of thing. It'll make you really weak, and a lot of people may not sweat enough, or sometimes if it's cold, they start sweating. Temperature regulation's rather goofy there. Now, we want to talk a little bit about exercise, because with Ehlers-Danlos, we have a much bigger risk of injury and dislocations. So we want to be careful of contact sports and weightlifting, and maybe even running too. If your knees are already not great, you're not going to want to run because that puts so much impact on your knees. But instead, some good exercise choices are things like walking, swimming, biking, even Tai Chi. Yoga can be good as well, but again, we want to make sure that we're being mindful about overstretching the joints. Another thing we don't want to do, we established that that your TMJ joints pretty sensitive. So we don't want to chew gum. I know a lot of people love chewing gum. You can have mints if you want that flavor, but you're not going to want to chew gum. You don't want to chew ice, and you need to be very careful about chewing hard things like croutons, like rolls, that sort of thing. Another thing, if this becomes a huge issue, if your joints are in a lot of pain, or you're just not able to, if you feel like you're just not able to move correctly, and we need to start thinking about exercising to strengthen the body and stabilize the joints, we can get into physical therapy, and that can be very, very helpful for that as well. So that's something we'll keep for down the line if we do these changes and it's not helping, okay? And the last thing, for chronic pain, for fibromyalgia, which often goes along with it, and with the ME/CFS, there have been some promising studies for naltrexone, a low dose of naltrexone, which at 5 milligrams, which is usually what we start with, there really aren't any side effects except sleeplessness for the first week, and you might have vivid dreams. So if we ever come across that, then that's something we can use. And we can go up in dosage as well, just depending on if your body doesn't metabolize it correctly. So that's always an option if we later find that you develop any chronic fatigue or the fibromyalgia, or if we want to try it for chronic pain, then that's also an option on the table. Okay? Okay, yeah, a lot of information that I just threw at you, but I have quite a few different resources that I can send you, and while I gave you a little list of comorbidities, that is not the end of that. There are many, many conditions that are associated with Ehlers-Danlos. So I'll give you a little list of that as well. And you may be surprised to find that you have quite a few of them. So that's something that also you probably want to talk about with your family, especially if there are children in the family. It's very important to know early on what can be harmful, and it's also helpful to know if you have all these odd quirks, why that's happening, right? So when that goes along with allergies, for example, we see a lot of chronic idiopathic urticaria, which is chronic hives. That's really hard to treat. So if we know it's from Ehlers-Danlos, that can help us narrow down a little bit, that sort of thing. It unfortunately is a connecting factor for a whole lot of things. Okay? All right. After all of that, did you have any questions at all? Okay. So let me go ahead and just jot a few things down here. So there we go. We are walking away with a diagnosis of Ehlers-Danlos, and we are advising on management options, and at this time we are not looking at any medication, right? Okay. So I think that about does it for us. Is there anything else that you need? Any other questions you have? Anything else I can look at? The blue sclerae thing. So that is harmless. It can be a sign of other things, but when associated with EDS, it is benign. There's nothing going on with it. Your sclerae are just blue. All right? Yes. So we are going to want to keep up on regular vision assessments, though, because EDS can affect your vision. So let me go ahead and order that genetic testing, and then we can figure out from there which kind we have. Although so far, since you haven't had many issues, I'm thinking it's probably not like the vascular type. So that should be good. All right. Well, thank you so much for coming in, and I'm really glad we got that figured out for you. And you've got a bit of reading to do, but this should help quality of life a lot more now that you know what you should be doing and what you shouldn't. Okay? All right. I hope you have a whale of a day and a good rest of your night. Thank you. Bye now. Thank you so much for watching. I really appreciate it. And a big thank you to my patrons on Patreon, without which these videos would